start with now introducing the first speakers. So please refer to the agenda for the timing of everything. There might be some changes during the day. One of our speakers is arriving late, so we'll have to see how that goes. But Dr. Christoph Licht, who most of you probably have heard of at least, maybe met, will be moderating throughout the day. We'll begin with a presentation by him and Jacqueline Leonard, who is a genetics counselor, for this first talk. And during that talk, one of our board members, Tom Curlow, he's a retired physician, he will be moderating that talk. So it's with great pleasure that I introduce Dr. Licht and Jacqueline Leonard for the first talk. Dr. Licht, special to me because he diagnosed me with aHUS over a decade ago. I was misdiagnosed for 8 years, and he finally got wind of that from via and thought we better do something and figure out if this is real. So he diagnosed me. He is one of aHUS Canada's medical advisors. He has been instrumental in helping us gain access to treatments in Canada because he helped us with advocacy, and I'm honored to call him a friend. And I will just read him and Jacqueline Leonard's bios, just in case you don't know them too well. Dr. Licht is a professor of pediatrics and medicine at the University of Toronto. He is head of the Division of Nephrology at the Hospital for Sick Kids, a senior scientist in the Sick Kids Research Institute Cell and Systems Biology program. He is cross-appointed to the University of Toronto IMS and LMP graduate schools. I'm sorry, I don't know what they are. He is associate staff physician at the UHN Toronto General Hospital. He runs a translational research program focused on complement-mediated kidney diseases, including clinical and basic research. He's established and is co-directing of the University of Toronto Complement Fellowship and the International Toronto Complement Conference, which I've had the privilege of attending a couple, so it was really good. And Jackie Leonard. She is a pediatric genetic counselor currently practicing at the Hospital for Sick Children. You'll hear that hospital's name quite a few times today. In clinical genetics and nephrology. She received a research master degree in pathology and molecular medicine in 2016 from Queen's University, and a master's in genetic counseling in 2017 from Brandeis University in Boston. She grew her career at the Children's Hospital in Philadelphia for over 7 years before she joined Sick Kids and Nephrology in fall of 2024. So welcome, Jackie and Dr. Licht.
Good morning, everybody.
Good morning.
Michael, thank you very much for this great introduction. You are a public speaker, by the way. And yes, you can have tattoos. And there will be footnotes to all of that, and that's what the day is for. So just one line of a personal response to what Michael said. It's more than just the usual thank you for the invitation and the opportunity to present. That as well, but it's really a privilege to be with you. I think we all have to congratulate everybody who has really taken this organization to where it is and what it's doing. This has become really more than a group of, people being in the same boat. This isn't really a family, and I really congratulate you on that. I think this is what it needs to be, and you have achieved a lot over, not so many years, and this is an amazing achievement. So congratulations to all of you. The idea of the day, and again, this is you, is to set a different focus, which is really to talk to each other about the burden of disease and how to cope with that. I hope that we can break the ice in terms of participation in the conversation, the discussion, asking questions as soon as possible, and really make everybody comfortable, and that this is we're not at school. This is not kind of testing knowledge. This is for exchange, and here is people who are willing and are grateful to be invited to share their experience, their knowledge, to help. And this is really an opportunity, and we should kind of get into this mode as quickly as possible. So please interrupt us, ask questions, and engage in the discussion. The idea of the first talk is for me to be really the pre-group to the real concert, which is Jackie Leonard's talk about, or part of the talk on genetic counseling, since I guess this is much closer to your interest and where the questions are than the systematic piece, which is my job. To kind of set the stage, lay the foundation, talk a little bit about systematics, and then basically take it from there. And we can always go back to those, let's say, more biological aspects whenever it's needed and meaningful. Disclosures, just to be complete. The disease that we are talking about. So the group is called atypical aHUS. And that's how you identify as patients for the most part. But really what it is one version of what we call a thrombotic microangiopathy. So it's a small vessel disease that has to do with endothelial, so inner lining damage, and the formation of clots. And the pathologist could not tell you what type of thrombotic microangiopathy you have, whether it's atypical aHUS, primary, secondary, or one that is driven by any other circumstances. That's what a pathologist would see under the microscope. That's one kind of photograph that represents that. If you dig deeper and kind of become a bit more systematic, it's this damage to the inner lining, and then kind of various features of injury to these inner lining cells. We call them endothelial cells. And then the clots that obstruct, I'm just going back for one moment, obstruct the openings, the lumina, as we call them, the inner openings of the blood vessels. They are clogged with blood clots. And that's why the organs fail, since they don't have blood supply anymore. So it's endothelial injury, blood clots, and obstruction of those blood vessels, and with that, the organs fail. Clinically, I mean, nobody has that written on the forehead. Clinically, those patients present with features that tell us that blood is clotting, so the hemoglobin drops, the platelets are consumed. That's this signature of the microangiopathic hemolytic anemia, and the platelets on top dropping, thrombocytopenia. And then we have this wide span of clinical phenotype that focuses on the kidneys. We're still not smart enough to really understand why the kidneys take the major hit, but it's a head-to-toe disease. So all organ systems are involved or can be involved: CNS, heart, lungs, gut, skin, bones, and patients with severe forms of the disease could speak to that. The reverse is also true. The advent of the treatments have put patients into a situation where they volunteer to say, I feel better. So this is not my kidneys work better or my heart works better or something. They just say, I feel better. So that really indirectly makes the point this is a head-to-toe disease and not just a phenomenon in the kidneys. There's a history of learning to that, and it's maybe interesting to you to, for one moment, reflect that this goes back 120 years-ish. That something that we call today TMA has been described for the first time in literature. And then this form of aHUS that is driven by certain E. coli like this infectious form, aHUS, you know it with various names, was described in like the mid last century. In 1955 is the paper published from a Swiss colleague. And then it is the beginning, it's the second half of the last century, the 70s and the 80s, where we started to learn this is not just a phenomenon, there's genes behind it. So we have familial traits, we have families where these TMA conditions show up. And we start understanding that this is actually a mechanistic spectrum. So it's not just what we call today the complement form of disease, but there's this form that we call today TTP. And we start beginning to understand how that works. That's kind of the begins in the 80s. It is not earlier than the mid-80s that we understand, and it was actually a microbiologist at CKIDS who contributed significantly that aHUS is driven by the toxin, the Shiga toxin that is produced by those bacteria. And then it is actually a paper in 1998 where for the first time a gene is identified that drives the complement-mediated form of TMA, which we call today the atypical aHUS. And then it's really just the last 15, 20 years during which we have made progress in terms of collecting all the genes, the antibodies, and then eventually, that's the last bullet point at the right bottom, the treatments kind of show up. 2011 onwards, eculizumab, and now many more, and we'll hear about that. So I think it's interesting to maybe just for a moment to reflect on that. I now introduced it a couple of times. It's a complement-mediated disease. I hope that we won't torture you with too many of these complement slides, but it has to be done to set the stage, so to make it understandable, why the genes do what the genes do and why the treatments do what the treatments do. For this slide, really, it's enough to kind of remember this is a portion of our immune system, and it's a good portion of our immune system. For a long, long time, this has been there, hundreds of millions of years, pretty much unchanged, and it has served us well as a first line of defense. It just defends us from the outside. Bacteria are basically attacked when they get entrance to our blood system and need to be removed, since otherwise they would remove us. And that's what this complement system does. It has these starting points. Can you see them? No, you can't. It has these starting points, immune complexes, or bacteria that kick it off, or it has this self-starting alternative pathway. And then it's just a forward cascade that in the end of the day produces something that attacks the invading microbe. That's this MAC complex. The system is super powerful, and it needs to be balanced by regulators. And you have both fluid phase regulators, so soluble ones that are in blood, or sitting on the surface of our cells to protect them, since otherwise they would be constantly basically attacked and killed by the complement system itself, right? So we need to be exempted from that attack. We don't want the bacteria to be exempted, but our cells the host cells need to be exempted. And this is shown here on this cartoon. If we take it slowly, maybe it's not overwhelming. This is how our cells take care of this business. So endothelial cells, so this would be the inner lining of blood cells or of blood vessels. And this complement system, I said, has a self-starting mechanism. So all our endothelial cells are covered with constantly with these activated forms of what we call complement factor C3. And if that was left alone, it would continue to activate to this MAC complex. And it is factor H, and it is complement control proteins, MCP, DAF, sitting on cells to inactivate C3b, to make it IC3b, which is here, so that it doesn't harm our cells, right? So C3 is spontaneously, we can control this, activated, it sits on the cells, and it needs to be stopped from progressing or kicking further off the cascade to prevent this injurious kind of final product to occur. And that is delivered by factor H, factor I, and those membrane-bound MCP and DAF proteins. There's a few more, but that's kind of the ones that are kind of best known to us. Now, this is basically the same cartoon again, but now if you look carefully, those complement control proteins, they come with little spikes. So that basically represents that they are now not doing their job, right? So it can be that factor I or, factor H or MCP or DEF, one of those is not working normally. And as I said, the end product is the cascade runs to the MAC complex formation, endothelial cells are injured, blood clots develop, right? So that's the balance that you need. The activation is there. It's good to have it, but it needs to be controlled for us. And if the control doesn't work, endothelial cells are injured and the clots form. And this is basically now everything you need to know to digest this table, which is the summary of basically what we more or less, I mean, this is not totally brand new, but it is still a good representation of the genetic forms of atypical aHUS. And I kind of made it a bit more digestible by framing in red mutations where function of proteins is lost. So we call them loss of function mutations. So think of this balance, activation, inactivation. So if defense proteins lose their function, the cascade runs in overdrive, right? So red is loss of function of complement control proteins, and you see now your what you just saw on the previous slide, factor H, MCP, factor I. Those are the major kind of proteins that will regulate if normal, and if abnormal, then they let the system pass and go into overdrive. So that's loss of function mutations. But you can also have drivers like factor B or C3. They are part of this cascade, this forward cascade. If they gain function, so they become more active drivers of the cascade, same end product. The balance tips over, too much activation, injury is the result. And what you can see is that they are not all happening occurring with same frequency. Factor H is the one that really stands out. And they don't come with the same risk of recurrence, progression to end-stage disease, and recurrence after transplantation. And just to be simple, we can go into each of them if you want, but factor H really stands out in terms of incidence, like frequency, and being aggressive and coming with a risk for developing end-stage disease and like having recurrence after transplantation. I mentioned this paper already, or indirectly this patient already. This is a newspaper-derived picture. That's why I can show it. So this is from if you want, the index patient, or an index patient, or a patient of a family that became the index family, that taught us what the genetic foundation or mechanism of atypical aHUS really is. This is a patient from Newcastle in the UK. And his case was, as you see at the right bottom, was published in the late 1990s. And at that time, we didn't have this easy access to genetic testing that we have today. So what was done at the time was, find all the family members, kind of learn from manifestation of the disease in several generations and in biologically related relatives, and do something that we call linkage analysis. So you try to link, the disease phenotype to a certain genetic phenomena. And really the summary of the slide is that, using that family over 7 generations, as you can see here, this is 7 generations of a pedigree. It's just fine print, and you're typically used to not seeing it in a circle, but it's just for space put into a circle. But that's 7 generations of a family, and you see many affected members in the fine print. And by doing, all the analyses available at that time, what came out was that a certain region on chromosome 1 segregated with this type of disease, not knowing that there is factor H or anything like that. And then only later they identified and published in the paper that the key gene in this case was factor H. So it begins with the patient with a phenotype. It begins with the digging into the families, the pedigree, to say, yes, there is a genetic trait, identifying a region on the first chromosome, which is represented here, and then finding out through further analysis that on the long arm, the second half of this chromosome, there is a region that drives aHUS, and then finding out that it is the region that encodes for factor H.
Could you just do me the favor of going back 2 or 3 slides? I had a question, but that one. So with the factor H, where it says ESRD after 5 years percentage, what is ESRD?
End-stage renal disease. So that's basically the progression to renal failure. Sorry.
So you're saying 78% of people will have that?
Yeah. This is historic data. In the era without the current treatments that we have. This is basically pre-eculizumab or
And
siblings.
When the eculizumab, what's the percentage?
I would claim close to 0.
Wow.
Yeah.
Okay, well that makes me feel better.
Yeah, but it bears the reason that we are going through that is not just nostalgia. This is not just historical interest. The reason is that we will have a little later in the talk the point. So now we are on treatment. Now we are in this privileged situation that we can use a drug that works. Do we do this now for the rest of the patient's life, or do we discontinue? And what is the implications of discontinuation? And that's why you need this, what we call natural outcome data, right? Yeah.
Thank
Any other questions around that?
Thank you.
Okay. I try to be quick with this one, but it is, since we're talking factor H, you see again the cartoon of the chromosome 1. You see the region where factor H is encoded. What we have learned subsequent to that is over years that there's not only factor H sitting, so this is kind of now up, going from the bottom to the top, going down on this chromosome 1. And there's next to factor H a couple of other factor H-like proteins. They are called in the literature CFHRs, related proteins. And I know that you, especially the ones with antibodies, might have or will have heard about these factor H-related proteins. This is even for us experts, this is a difficult subject matter. But we have learned quite a bit about it. And there's a couple of things that you may be interested in. So they are sitting in neighborhood. It's number 1. Number 2, these related proteins are somewhat of the the small siblings of factor H, and small in any aspect. They are smaller, they're shorter, but they're also smaller in function. They are less potent, but they are kind of doing similar things as factor H. The trick with these related proteins, these smaller siblings, is that they have, through specifics of how the genes look like, a risk. And the risk is that they start to scramble up. They can be lost. They can amplify in number. They can duplicate, triplicate, and they can merge. They can fuse. And that's shown on this slide here, where you see that in aHUS, you can have deletions, so you lose them. You can have duplications. You can have deletions that result in the merging of pieces that are not belonging to each other, but now they are kind of just connecting, since that's what those sequences do. And they produce then a new protein that's just not doing what's meant to be doing. They can duplicate, same consequence. The product doesn't do what it's meant to be doing. Or they can be lost, and then that's the situation that genetically is linked to, in many cases, to the antibodies, and we'll have a talk about that later in the day, right? So just be aware of, there's a family of these proteins. They're kind of very interesting in terms of their biology, but they come with the risk of these, what we call copy number variations. So they kind of scramble together. They are lost, or they're duplicating or triplicating, changing their number. And all of that results in loss of function and disease phenotype, as in atypical aHUS. I skipped this here. One of the questions that we had in that Michael presented was the difference between primary and secondary TMA. So this cartoon summarizes the story kind of nicely. Endothelial cells, the inner lining of the blood vessels, you're familiar with that now. Here, this is basically injury, blood clot formation, right? That's when TMA or aHUS starts. And now the story of this picture is that you can have that scenario for two reasons. One reason is what we just spoke about all the time. It's this primary complement-mediated form, where the system here, this cascade, is just attacking the endothelial cells. Since you have one of those defects, a genetic defect, or you have antibodies, endothelial cells are attacked, and the blood clots form, right? However, you have also this second kind of box of scenarios where you don't have mutations, you don't have antibodies, but you nevertheless have a clinical phenotype that is indistinguishable from primary atypical aHUS, and you most likely have, for some time, the involvement of the complement cascade to make things worse. So I'll repeat that. With the primary form of atypical aHUS, based on genes or antibodies, you have this overdrive of the complement system, and you have the yellow box kind of mechanism, constant attack to the endothelial cells, and the phenotype as a result. In the purple box, you have a phenotype that really looks like the primary form, but you don't have the genes, you don't have the antibodies. But you have probably a temporary involvement of the complement to enhance hypertension, the side effect of drugs, an infectious situation, some autoimmune phenomenon, and complement just makes that worse for some time. So you have a window of opportunity during which complement is involved, and you're able to interfere with that with your treatment. I think, Michael, you had a question.
Could you just clarify for everybody the difference between genotype and phenotype?
I'm sorry. So when I'm talking about genotype, I'm relating to genes, mutations, and then the phenotype is basically how the patient presents, the symptoms with which the patient presents. I'm sorry. All this jargon stuff, I try to not use it, but stop me when I'm doing it. Yeah.
So, secondary aHUS, like when our child was hospitalized, you know, they were saying, well, maybe before they was diagnosed with aHUS, they were talking about like that he maybe would have had just E. coli or something like that.
Yep.
And secondary aHUS is not the same as that, is it?
That's a good question. I don't have a slide for that specifically. To be simple and as close as possible to the global consensus, the answer is no. So Shiga toxin aHUS would be outside that. So we have primary, secondary, we have Shiga toxin aHUS, and we have TTP. That's kind of the lay of the land that most people would agree with.
I can't get the first part, but the second part of the word is toxin. That would have been the sort of bad meat.
Yeah, exactly. Yeah. Please.
Sorry. How do you know if you're primary aHUS or secondary?
I mean, this is probably the best question of the day. And okay, sorry.
And the second part is when you're in the primary, the symptoms that you're describing, is that when you are without, is everything presently without the medication involved? Everything that you're talking about so far?
Yeah.
Without
Yeah.
medication?
This is this describing mechanism of disease, and then the idea of the treatment is to reverse or stop that mechanism. Yeah. So how to diagnose? Again, this is a talk in its own right. It's in the first place. The first diagnosis is a clinical diagnosis. It's to observe what I have shown on the second slide. The pathologist is not the first one who sees a patient. The first one is a clinician who sees a patient with symptoms. The blood, the lab values that are different, and the organ involvement. That is what tells us this is a patient that probably has a TMA. And then our job is to exclude basically these secondaries. A 5-month-old baby will not be a pregnant woman. So we can exclude many of those right away. In the end of the day, the confirmation for the yellow box will only be, the positive confirmation will be the presence of a mutation or antibodies. And again, this has implications for treatment later on, but that's really the truth. So before you have that, you can't really be 100% sure. And many of you in the room, we will have had conversations with where we kind of had to leave you with this uncertainty. We have an impression, we have some sort of patients to compare to, but we can't give you a guarantee in terms of the diagnosis unless we have a mutation or an antibody proven.
That's only through genetic testing?
Yeah. Yeah, so it's in the correct answer to your question is it's a diagnosis by exclusion.
So has that kind of been updated? Because I kind of thought it had to do with hemolysis of the blood. Is that kind of the old-fashioned way of that?
Well, that's the first step in all patients, to see that. But then the question was, how do you know which form of diagnosis is underlying this phenomenon of hemolysis? Yeah. I'll try to finish this up so that Jackie can continue. So the maybe just to highlight the work of one of our speakers, Dr. Chioetio, later. We have some ongoing research that gives us an idea. So one of the questions that you didn't ask is, how is this here possible? How is it possible that drugs or certain autoimmune conditions or transplantation or hypertension, how is it possible that that gives me a complement driven problem? I'm sure that some of you at least thought about that. And the research that Dr. Cho has published kind of gives at least one possible explanation. So I hope that this is now somewhat familiar. Endothelial cells again, so the inner lining of the blood cells, the blood vessels, the complement cascade, self-activating C3b sitting on the cells, and under normal circumstances, factor H, factor I, MCP, cleave C3b inactivated, stop damage from occurring, right? For that, you need factor H to be present on the cells, right? Factor H needs to come from the blood, from the plasma, and bind to the surface to do its job. And if it's not possible, if it is not able to do that, then it can't help. It can be there in normal amount, but it will not be able to do its job. And both factor H mutations and factor H antibodies do exactly that. They prevent factor H from binding to endothelial cell surfaces. That was actually this slide here. So most of the mutations of factor H are sitting at the end of the protein where it's binding to the endothelial cells. So what Dr. Teo has shown is that if you lose the accepting binding sites on the endothelial cell surface, you lose basically this factor H mediated complement control. And that could be a link between all these conditions and complement in a situation where you don't have any mutations or any antibodies. We can talk about this more if you want. 2 last slides and then I'm done. It's now back to clinical translation. Most of our patients, and you will have experienced that yourself or your children, most of the patients who present with atypical, majority of the patients presenting with atypical aHUS do that subsequent to what we consider a triggering event. So some sort of an infection, this is a fine print list, but vomiting, diarrhea, and infections are the top hitters. This is basically all the list of possible events that can be triggers. And the significance of that is that we think about, since another phenomenon in this world is that not all the carriers of the mutations or antibodies present with the disease, right? Not everybody develops the phenotype. You may have the genotype, you may have the mutation, but you may not have the phenotype. So what you probably need is 2 hits. You need an underlying risk factor, could be a mutation, could be antibodies. And then on top of that, you need a trigger, which is, as you have seen on this previous slide, often enough an infection. And together, they then kind of, cross the line and make you sick. And the more severe your mutation is, the higher your antibody titer is, the higher the risk that any trigger tips you over. Right? So that's the learning point from here is that those mutations, those antibodies, in combination with the environment, give you the disease. Right? It's this 2-hit concept.